So particularly going on cellularity, if the cellularity is increased, and there is definitely increase in the myeloid erythroid ratio around 5 or above, then that is a myeloid hyperplasia, which is commonly seen in leukemias, chronic myeloid leukemias, myeloproliferative disorder, but this is also seen in reactive leukocytosis, or what you call leukemoid reaction. As far as my experience goes, only on the bone marrow, it is not possible to differentiate whether that is a chronic myeloid leukemia or reactive hyperplasia, unless you have a clinical history and massive splenomegaly. That is very difficult to distinguish. This is my experience, though most of the times we think that the diagnosis of chronic myeloid leukemia and very easy. But without splenic enlargement history, I will not dare to give a diagnosis of chronic myeloid leukemia, though the cell count may be more than 1 lakh. This is my experience. And even immature cells, the 2 instances I had this problem. A young patient having the total WBC count of almost 1.7 lakh with immature cells, what you see in chronic myeloid leukemia. The best way is to have communications. Though the means of communications have increased, it is become easier. But what I am observing is there is a very large gap in a communication between pathologist and clinician. That is increasing day by day. So I went to the consultant and he was sitting with the X-ray of that young man. There was a lobar pneumonia, that case. Another case, a young person of 18 years came. The count was around 20,000. And what I observed, even the blasts, myeloid blasts, 1 to 2% were seen with myelocytes, metamyelocytes. When I rang up my consultant who had sent this, well, just don't bother, I will send you this patient after 8 days. He had taken analgesic and had frank melena. He will bring the stool in the evening. Yes, that was tarry black in color, strongly positive for blood, and to my surprise, all these cells disappeared and there was a normal cellularity in the peripheral smear after 8 days. So these are the cases. Why I am telling? Because you learn a lot from the cases, not by reading from the book. That is what my aim here is. Besides that, of course, you may get eosinophilia. Particularly, these are the conditions we teach to even MBBS students, what are the causes of eosinophilia. Now, another thing what I felt is, in books, some of the olden books, they are giving only basophils. Nowadays, they are giving basophils and mast cell. My concept was mast cells are the basophils in the tissue. Okay? And still, now, I don't know why they are differentiating, but there is no way to differentiate between mast cells and basophils. I went to the details. Their origin is same. Then why they are calling it different? Really, at this age, I cannot answer you. If anybody get the answer, yes, definitely I will like to learn from even if that person is junior. Okay? There is no age bar for learning from anybody, isn't it? Then another thing, any increase in the plasma cells, about 30%, now the standards have changed, is taken as myeloma. No. I have seen reactive plasmacytosis going up to 40% misdiagnosed as a plasmacytoma. And this is nobody but my own Bhabhi. Because they were going to give the chemotherapy and I refused. Because I told them, unless you do it, the monoclonality of the cell and prove, don't give chemotherapy. Because she was suffering from psoriasis for last 15 years before they did the biopsy. So don't think that plasmacytosis in the bone marrow, that will be immature diagnosis without knowing the history of such diseases. Remember that. Because that is very easily given and confidently given nowadays. Okay? So these are just so besides autoimmune diseases, there may be chronic inflammatory diseases. This has been known in even rheumatoid arthritis and other collagen diseases. These are just to give a break from listening, these are the figures and you must have seen. Another thing is the most difficult diagnosis which we come across is to distinguish bone marrow hyperplasia of any leukemia or myelodysplastic or anything from splenic hypersplenism, hyperfunctioning. And for hyperfunctioning spleen, I can tell you that spleen need not be massively enlarged. And this diagnosis is diagnosis of exclusion. Mostly this comes from the surgeons because they want to remove the spleen. And the patients may have any type of simple anemia to pancytopenia, anything. And if you don't go into the history of this, and definitely there is no way to prove hypersplenism. This is just an imaginary way. They have bone marrow with pancytopenia is normally morphologically normal or hyperplastic. Yes, you can suggest, and though they go for splenectomy, and definitely there is a marked improvement in the patients. That's what I have seen. I have gone into the details, tried to find out the different way to diagnose hypersplenism. No, they are all indirect ways. Okay. Then polycythemia vera. Yes, mark hyperplasia, but almost all the elements are hyperplastic. Then this is the myeloid hyperplasia. The agranulocytosis is another condition. I don't know whether this is commonly seen nowadays or not. But mostly even the MBBS students, they don't know, because agranulocytosis was a very common question asked in MBBS examination. And mostly that was associated with chloramphenicol. But to my surprise, I have seen a case of particularly a pancytopenia and thrombocytopenia associated with installation of norfloxacin eye drops. This patient was prescribed eye drop. This was a patient from Dhar, and my Nanial is in Dhar. So I don't know that she came with multiple pinpoint hemorrhages. Of course, marked thrombocytopenia. She was referred to the hematologist. He confirmed. The only history was Norflox installation for conjunctivitis. And she was prescribed for 10-15 years, and she was putting those drops for almost more than 6 months. So we should be beware of any drug. Any drug can cause any type of reaction. Unfortunately, then she was treated. And then one day her husband telephoned that she is getting headache. And then I asked the hematologist, don't bother, she is all right. And next morning she was dead of cerebral hemorrhage. Okay. So such instances, they teach you a lot, and that by references you can remember them easily. Okay.